Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Joining me as we cut through the fog that frequently exists at the leading edge of healthcare technology. My guest today is Michael Meucci, the Chief Operating Officer at Arcadia Analytics. Arcadia is a market leader in enterprise population health management platform and applications. Michael, welcome to the show.
Jim, great to be here.
You know, I've got kind of a general question to ask you first, Michael, before we start talking about data. Arcadia Analytics. Why Arcadia? Why would you pick that for a name of a company?
Oh, I thought you were going to ask me why I'm so handsome.
That's my second question.
Okay, perfect. You know, our founder was a native Rhode Islander, and there's an Arcadia Park right around where he grew up. And so he said when he started his company, I want to name it Arcadia. He actually, his prior company was also named after a landmark in Rhode Island. So there's a theme there. Okay,
good. Yeah, I'm always fascinated by those kind of things. Well, you've already let us know how you got to be so good looking, so we'll skip that second question. Michael, we're going to talk about data some today in a couple of different ways, but, you know, some of the things I've read about Arcadia Analytics and your work there is to kind of envision data as a supply chain concept. You know, I've been involved with healthcare data a long time, but I never thought about the supply chain aspects of it. So could you tease that out a little bit?
Absolutely.
I like the idea of it. Teach me on it.
Yeah, absolutely. It's actually a new concept that we've been socializing over the last couple of months. Mm-hmm. The idea is that I guess maybe before I explain the data supply chain, let's just talk about supply chains in general.
Great.
So you have companies like Blockbuster, and Blockbuster was a household name for decades, and they were in every city, every town. We all had Blockbuster membership cards. Every Thursday or Friday night, you go rent your videos, you'd get your candy, your popcorn, you go home. And, if you were good at rewinding and returning, you'd not get a late fee. And, along the way, Blockbuster launched a direct-to-mail product, but it didn't really take off. And then Netflix came along, and they did the same thing, and it did take off. And so you have to ask the question, what changed? And what ultimately changed there were two hops. First, there was this hop to optimize the supply chain of how we consume content. And that first optimization was you don't have to get in your car. You don't have to drive to the video store. You do miss out on buying candy, but we solved that supply chain problem later with DoorDash. And you get your DVDs mailed to you. You mail them back. You can keep them as long as you want. There are no late fees. It really optimized the consumer experience. And then there was this second hop, which was this hop to digital media, delivering streaming content over the internet. And that really needed a bunch of infrastructure build to be possible. When Netflix and Blockbuster launched their direct mail product, they had the USPS, they had UPS, there was established distribution channels. But at the same time, if they would have launched a streaming service, there wouldn't have been as captive of an audience because high-speed internet, enough to support high-fidelity streaming, wasn't broadly adopted across the United States or affordable for that matter. So you have these two optimizations of the supply chain, and they're both driven by consumer experience. And if you look at a bunch of the Silicon Valley tech companies, Netflix, Facebook, Google, they've all been focused on improving the user experience. And that's the core grain of why we focus on the supply chain, is because first, the most effective supply chains in the world, the most disrupted supply chains in the world, are the ones that focus on you as a consumer. Mm-hmm. And second, because the second reason is that when you think about healthcare data, there's been this long-running moniker in the industry that those organizations who have the data are going to win, or data is my most strategic asset. And that's just not true. The organizations that are going to win are the ones who know to take that data, turn it into something meaningful, and not just an insight, not just a report, but really a product that you can push out to a provider and say, hey, doc, we launched this new risk score, and this risk score tells us that this patient is really, really likely to not be able to manage their own care because they've got really high social needs, and until you address those social needs, they're never going to manage their diabetes. And get that into the right place at the right time for the right person. and then build a feedback loop so you can keep learning from it. So I'm going to go back to Netflix really quickly.
Okay.
And Netflix launched this mail product, and then you could have 3 DVDs out at a time.
Right.
And you've got Blockbuster and Netflix, both with a mail product. Wouldn't it be logical? Blockbuster was this household name. Everyone had the membership. Why did people flip to Netflix? And why did they use the Blockbuster mail product? Well, first, Blockbuster had a vested interest in their real estate holdings, so they wanted to keep the brick and mortar stores open as much as possible.
Mm-hmm.
Second, Blockbuster had 3 distribution centers across the country when they were distributing content. I actually just learned this a couple of hours ago. Netflix had 35. So when you wanted a new DVD from Netflix, you dropped it in the mail and you got it back, within 2 days. And Blockbuster, it might have taken a week. So while we think about the consumer experience, they both had the same idea. Reduce the friction, increase liquidity. But at the end of the day, what Netflix did that Blockbuster didn't is they focused on what's going to make the consumer happy. And it was speed. Amazon takes a huge loss, or used to take a huge loss on Prime memberships for the same reason. They knew that getting products in people's hands within 2 days would be enough and fast enough to get them to say, I don't want to go to Target. I'll just order on Amazon.
Right. Yes.
And so it's this consumer experience, and those are products. Amazon Prime is a product. Netflix is a product. And they have these feedback loops. And now you're looking at Netflix, and they're branching out into building their own content. They have all this analytics on what do people watch? How do they consume content? Do they binge content? Do they watch it on a weekly basis? What age groups want different content? And that feeds into the way that they're building and developing new shows. So again, I'm going to come back to data now because that's where we live every day. And that's what healthcare needs to think about when they think about data. The way that healthcare has worked with data historically is really slow. I've got an EMR, and I want some information out of my EMR. So, let's just say I'm a clinical informaticist, and I want information out of my EMR. That may mean that I go to my CIO or my VP of IT, and I say, okay, I need social determinants data out of my EMR. And they say, okay, great. Well, we don't currently get that in our data warehouse. You're going to need to write up a project spec for an interface build to pull data out of a prepare template out of the EHR. Okay, great. We size that. That costs a little bit of money to build. It's going to take 12 to 14 weeks. But we got to get it scheduled because there's a never-ending list of compliance, upgrade, IT projects. So maybe from the point that a business user says, I want data out of these prepared templates, to the point that the interface gets built, it might take 3, 4, 5, 6 months. From there, you go back to your data analyst who's asking this question, this informaticist. That data's in their data warehouse, and that point that it's in there is probably the first or maybe the second or third time they've seen the data. Maybe they saw it in testing the interface. And now they have to ask the question, okay, what do I do with this data? What product can I build? How do I get this data in front of a provider or in front of a care team member who can do something with it, make something of it? And that's before you even see the data payload. What would that look like if instead of having to wait 6 months to ask that question, if that clinical informaticist could say, we've got this massive data lake, and in this data lake is effectively a full copy of my EHR file store. And I'm going to go and run a query against the lake, and I'm going to enhance and enrich the data at the point of query. Instead of having to go through an interface build, conform it to my specification, normalize the data, and just do a POC. What does this look like? And maybe they find, wow, the data I want in these prepare surveys doesn't exist. So then they go back to the lake and they start looking around and say, okay, I actually found what I want. It's in maintenance and observation items in the EMR. So I'm going to build a process to repeatedly conform and normalize that data into my data layer. And now I'm going to bring my business stakeholder to the table and say, okay, you asked me for prepared data. I found the prepared data you wanted, but I found all these other items in the maintenance and observation section of the EHR. I've normalized a bunch of data. And by the way, I've done some cursory analysis to say, here's some correlation analysis that says, patients who have food insecurity are much less likely to be able to manage their blood sugar levels. Okay, great. That's a really interesting finding. Now, what do we do with it? And the business stakeholder or the clinical stakeholders can say, wow, what we really need to do is get these insights to our community needs teams or our consumers and teams. We've got partnerships in the community with food kitchens, and we need to put that into a registry, and we need to be able to drive automated outreach to our patients to let them know that we've got programming available and track their responses. And that's product development. And the end result there is all about reducing the time to insight, but extending that supply chain to say, what is the user going to do with this? So much of healthcare data is about producing a report or a dashboard in Tableau or Power BI.
Sure.
And the analytics products that we actually need are so much more vast. We have many different delivery mechanisms. You can push data back into the EMR because of all the great work that the Karen Alliance and HL7 and Argonaut and FIRE have done. And so we need to think about data and data products as a true product. So that's what we really think about when we think about the supply chain, is how do you be consumer focused,
Sure.
user experience focused, and constantly think about cutting out the fat. Healthcare organizations are the suppliers and the creators of their own materials.
Yes. Well, and so what's Arcadia doing? What do you develop? What kind of processes or applications do you have to solve that or expedite that or remove friction from that?
That's a great question. So we are one of the leading and most trusted data platforms in the industry. We work with a number of the top 500 IDNs and top 50 health plans across the country, and we do just this. We work with our customers to take the data they have in the variety of silos across their organizations, drop it into a really fast data lake, and give analysts access to that lake to transform, enrich, and normalize that data in real time. And at the same time, we have a set of applications that sit on top of that, the products that take the most common workflows, use cases, care pathways, and put them in the hands of users. So I just got off of a presentation with the chief analytics officer and the interim chief executive officer of Castell. And Castell is a population health services organization that's wholly owned by Intermountain. And we've worked together for a number of years. They deployed our platform, and they have a really amazing advanced analytics team and analytics product team using our platform to develop the products that their care delivery teams use every day to provide care. And they use our care management solution to drive patient engagement. They use our patient outreach and text messaging tools to drive high volume outreach and engagement campaigns with patients and providers. And they use our analytics platform to take insights that we can create, because every health system shouldn't have to recreate the wheel and build their own implementation of a HEDIS measure or their own implementation of a risk model. What they should instead be doing is looking at the unique attributes of their population and building their own models on top of it and distributing it through those distribution channels, whether that's Cerner or their EMR or through our care management tool or some of our point of care notification tools. So Arcadia focuses on bringing together the data that we're creating and making it highly liquid for a variety of different data stakeholders.
Let me kind of bring up kind of a collateral question here that I've been kind of wondering about. So the whole concept of healthcare data from the EMR or the place of service or point of care, everybody wants that data, most relevant data on time at the right place for the right patient, essentially.
Yeah, we heard that forever.
Yeah, we've heard that forever. And then we have these, I guess you use the term data lakes, where you've got a gigantic amount of data and you can do some population management inquiries and figure out what's happening and which zip codes and all those kind of things. But then with the COVID pandemic, we have people at the national level making decisions based on data.
Absolutely.
And so different hospitals all over the country are reporting data might be a little bit different from one place to another.
It was in the news this morning.
What was it? Tell me.
Oh, yeah. There's this wild COVID spread in Florida right now, and the CDC in the state of Florida are arguing about the number of COVID positive tests.
Exactly.
And that's the problem with healthcare data in this country is that's super binary. Could you imagine if you logged on to Bank of America or Chase or wherever you bank, and your bank account balance one day was, $5 and the next day it was $10, but nothing changed. You didn't debit or credit anything. And then you go back the next day and it's like $5 again. What's going on? I wouldn't trust my bank. We don't tolerate this level of unspecificity anywhere else, but we tolerate in healthcare data.
There has to be a national response from, I guess, the National Institutes of Health, from CDC, and I guess there's a White House group that are putting out guidance, and the only thing they can do it on is based on data.
Right.
Hopefully, they're doing it on data, but it is, I don't know if cluttered data is the right thing, but, for most of us, this is the first pandemic we've lived through, and we can't wait 6 months to gather the data and make decisions. It has to be made. And so what could be done to increase that? You know, these disparate types of data coming in, but you're being forced to make decisions really without all the information that you need. What are your thoughts on that? Yeah,
it's a fantastic question. It's the exact use case around why we as an industry need to band together to solve the data liquidity problem. And I'm not saying you've got to go buy Arcadia. There are a bunch of people who focus on this. But broadly, there's a lack of data governance. So I'm going to take your COVID question and bring it down to a small scale.
Great.
We do a bunch of work with healthcare systems, and one of the biggest things that they like to measure is readmission rates. It's a pretty standard measurement in healthcare. Yep. I have one customer who has 3 different ways of defining the same thing, depending on which department you ask. Some folks say, well, I've got my own definition because I want to trigger an alarm long before I'd be hit with penalties. Their compliance team is tracking it from a compliance perspective. That shouldn't be the case. Again, it's like if Bank of America reported your balance 3 different ways, you'd say, well, what's my balance? I got to know how much money I got to spend. So going back to the COVID discussion, we have to answer the question, why is it so hard to have governance around this data? You know, why is it that we can't say this many people had a positive test? And, you know, they say, well, you know, maybe we don't know because there's false positives. Okay, great. Footnote the data and say that we know these tests are imperfect, but these are the number of positive tests that were produced. The other challenge, and I've talked a lot with, I'm sure you're familiar with Meucci Tripathi.
Sure, of course.
So Mickey worked for Arcadia for a while, and he's a longtime friend in the Massachusetts community of mine. And we talk about this problem all the time. Because there's this attitude that data is your most strategic asset, everyone guards their data. They know this is mine. It's my data. It's my competitive advantage.
I paid for it. Yeah.
I paid for it. I created it. And, you know, at the end of the day, healthcare systems don't own their data. Patients own the data. Patients are the ones generating the data. Now, granted, do healthcare systems have some right to the data because they're treating the patients? Absolutely. I'm not here saying that, you know, Beth Israel shouldn't be able to use the data they capture in their own EMR. But while it is an asset because it can be monetized, it's something that has great community value that we need to be thinking about how do you bring together. Certain states have done a really nice job with this, whether it's an all-payer claims database or really, really well-adopted vaccine registries or disease registries, and others don't. And I think that we need more, I'm probably showing a little bit more of my political leanings here, but I think we need more top-down direction on how we share information across data stakeholders so that we don't have this problem where every single state is reporting on their own vaccine rates and you can't compare, you know, the vaccine rate in Vermont versus Massachusetts because they do it differently.
Yes. Yeah. Before I ask a question, follow up on that, let me say to our listeners who may have just joined, you're listening to the Tate Chronicles. I'm speaking with Michael Meucci, Chief Operating Officer of Arcadia Analytics. The COVID experience, statistics on top of data, you see where, maybe some state, the immunizations are up 41% in 2 weeks. Well, that doesn't really mean much to me unless I see the raw numbers underneath it.
100%. Percentages are just percentages.
Yeah. And so I kind of, trying to draw conclusions based on that, I know that could be used to try and show that things are improving or getting worse or something, but I hope no real decisions are being based on those kind of things. Data, one thing you kind of mentioned about data, even if we make it liquid, that concerns me is that sometimes the data is inaccurate. I'll give an example. Sometimes, because of insurance purposes, a provider wants to prescribe a medication that is off-label.
Sure.
But the insurance company will cover it if you give them a particular diagnosis. So a diagnosis that is not accurate is given.
Yeah.
It's just, it just has to be done. And so that becomes part of the patient record. And so there's probably many examples of things like that. Interoperability, we're trying to have the most efficient plumbing underneath everything, but also, just the accuracy of that data. I don't know, you used the term for it a little while ago, Michael, but, that's critical too, that we have that in there.
Well, I think the thing that's really interesting in healthcare data is that it is not perfect. And that's why all these parallels to the banking or the finance industry aren't really fair. Because at the end of the day, finance and banking is just a set of debits and credits.
Yes.
It's much easier. It's much more straightforward. So you're absolutely right. There's a lot more clutter in healthcare data, and there's narrative in healthcare data. You have notes, which
exactly. Sure.
I don't care who says they've got the best NLP. We've heard it for years. It's still not. Our artificial intelligence on note reading has not reached the point of comprehension that a human can. So you're right. There's inaccuracy in the data, and so there has to be a healthy degree of caution as you start to think about how to make decisions on the data that we're presented with. But that's actually a key underlying component of the data supply chain, which is how do you understand the fitness for use of various data sets?
I like that phrase, fitness for use.
It's one we talk about all the time because, it's so interesting. So you have a customer who will say, okay, I want you to bring in data from Cerner. Okay, we bring in a whole bunch of Cerner data. We put it through our quality engines, and we'll say, hey, we looked at all this Cerner data. It's great to use for quality measurement. We think it's spot on. It's pretty good to use for risk adjustment and risk modeling. And then we'll say, but it's missing, we're missing a couple of different domains. And so we'd really caution you against making financial decisions off of this data because maybe we need to go get data from your ERP system. And there's a hole in that data. And so what we would say in our parlance is the data has high fitness for use for quality, high fitness for use for risk, but proceed with caution on financial analysis. And I think that we need to be thinking about the accuracy and the fitness for use and the completeness. Completeness is another factor that's really important in making a decision of how to use that data and where to use the data.
Yeah, I love those phrases, completeness and fitness for use for financial versus clinical versus research purposes, I guess. The whole, we're gathering so much data now. The whole press for interoperability at Dream, a lot of the standards are in place for gathering data and exchange of data and the code sets behind the data. So we're gathering a lot of data. I'm sure we're going to get better at being selective about the quality of that data. But in the whole, and things like that Arcadia analytics are developing to be able to analyze that data in ways that bring actionable conclusions. That's going to continue, that part. But as far as the gathering of data and interoperability at the point of care, where are we in that trajectory? We started at ground zero and we're trying to get to the moon. Have we escaped the Earth's orbit yet?
It all depends on what point of care we're talking about.
Exactly. Yeah.
I mean, so it's really funny. This is just like, when we talk about data and you say, well, how good is the quality? And you're like, well, that's too broad of a question to ask.
Sure.
So a couple of things. First, we have multiple people who work at the point of care. You've got physicians, you've got nurses, you've got front desk admins who are scheduling appointments. And I think that there's a lot of ease to get data to various different members of the care team. But then we still live in a world where, you've got Epic, you've got Cerner, you've got eClinicalWorks, NextGen, whatever.
You're getting flu shots at CVS.
Yeah, exactly.
Yeah.
So when you think about the point of care, let's just narrow the question to your PCP or a specialist.
Sure.
If they're on Epic, Epic has done a great job investing in the App Orchard. We're building in the App Orchard. We've got Fire R4 interfaces pushing data into Epic to drive clinical decision support, to trigger best practice alerts. And we're really thrilled about that. The team at Epic has done a really nice job of making it easy for people who have data to push data into the workflow and enrich that provider experience and really work on driving provider satisfaction by not asking them to leave their EMR. I won't name names, but not every vendor makes it that easy. Some vendors either, they've been struggling with how do they survive in a landscape that continues to consolidate. Other vendors feel like, I want to own the data. I want to be the one who gets all the data. And again, not naming any names, it creates a lot of conflict because some providers say, well, if I close my front end, my point of care to outsiders, that just means that someone's going to buy more from me to go buy my data solution. And I'm exceptionally biased here, but EMR vendors aren't data companies. They build transactional systems. And yeah, they capture a bunch of data, but we've got a bunch of great data companies in the room here today who have dedicated their entire focus to data. And I think that, just like I don't want to go build an EMR, I think the EMR should think really hard about, do they want to go build data lakes and data liquidity products?
Exactly. It's kind of amazing, Michael. We're almost totally out of time here. Before we have to sign off, how can folks get in touch with Arcadia Analytics to talk to somebody or learn more about your services? What's the best way to reach you?
Best way to get us is through our website. We can be found at Arcadia, ARCADIA.io. And if you're in Las Vegas this week at HIMSS, we're exhibiting on the booth floor. I think we're booth number 3416.
Okay, great. Well, to our audience, thanks for joining me and my guests on this episode of the Tate Chronicles. And I offer a special salute to Michael Meucci, who's the Chief Operating Officer at Arcadia Analytics. Michael, thanks for coming aboard today.
Jim, thanks for having me here. Have a great rest of your week.
I really enjoyed it. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.